Hello, my name's Diane Dutoy. I'm a clinical nurse consultant in dialysis and vascular access. I have 15 years experience in the dialysis setting and have been using ultrasound in dialysis for the last 12 years. I certainly believe that it's an essential piece of equipment in the unit for assisting staff in assessment and ultrasound guided cannulation. I'm going to talk a little bit today about assessment and ultrasound guided cannulation for dialysis nurses. Our objectives today will be to discuss the basic ultrasound principles. I'll describe the benefits of ultrasound for the dialysis setting. I'll identify some anatomic structures that we'll see on the ultrasound image, particularly when we're scanning arteriovenous fistulas and grafts. We'll look at how to create a map of the arteriovenous fistulas and grafts utilising the ultrasound, and look at how we can successfully insert a dialysis needle into a phantom arm using ultrasound guidance. So a little bit of history. Certainly when I started in the dialysis unit, we didn't have ultrasound, so we were taught to look, listen and feel and then cannulate. This only gave us part of the information. I used to always wish we could see inside. So the ultrasound allows us to actually look inside, not just go by what we're feeling and what's on the surface. Ultrasound is already utilised in other areas to aid central line and peripheral venous cannulation, and it's certainly considered the gold standard for CVC line insertion. Some of the benefits of ultrasound that I've seen: it's an adjunct to standard clinical assessment. It's another tool in our toolbox that helps us to do the assessment and also to cannulate. We can capture images and save them for future reference. We can also upload those images to electronic records, send them to surgeons or nephrologists so that we can request assistance if we've got any concerns about Images can be saved and uploaded for future reference so that we can look back and do a comparison, but also to send to the surgeons or nephrologists if we have any concerns. It helps us to choose optimal cannulation sites. We certainly do our best to choose the cannulation sites without ultrasound, but we're missing the ability to decide the depth. We can guess that it may be a bit deeper because we can't palpate it or because we can't hear it very well, but how deep it is, we're not sure. So unfortunately, we couldn't say, oh, it's too deep to put needles in. It also is a lot more difficult to cannulate a deep fistula because if you're slightly off track and it's shallow, you'll still hit it. If you're slightly on track and it's deep, you could completely miss it or just put a hole in the sidewall and cause a big hematoma. So you can see on this image on the right here, I've created a map. I've drawn it on the patient's arm, and this arm had a fistula for a year that wasn't being used because the staff had multiple difficult cannulations. So I was able to draw a map, take a photo of that and save it in their records so that staff could see where the bends and turns were and how deep it was. And then they were able to successfully cannulate. Some of the other benefits: it helps us to identify problems that we maybe wouldn't be able to recognise by just feeling or looking at the surface. Like I'd already said, deep vessels or areas of previous infiltration, stenoses, thrombus in the vein, all those sorts of things. Valves, it's not always easy to tell that there's a valve there and it will feel fine, or a branch in a deeper vessel. You may not realise it's branching off and you then thread incorrectly. I find it really helps with staff training. You're able to visualise what you're feeling and visualise what you're listening to, and you learn a lot quicker when you're actually able to see the picture and then feel and say, okay, that's what I'm feeling, that's what that feels like. This is the centre of the vessel, this is the wall, this is a branch, this unusual thrill is a little branch or a collateral, or this is a stenosis. So it really helps us to be better trained even without ultrasound. So I find that it's a fantastic tool for teaching staff. It helps us to visualise our insertion of the needle, and this is really important with difficult cannulations, but in my case I use ultrasound unless it's a big rope up their arm that's very shallow. If it's not easily palpable and it's a small diameter, I will always use the ultrasound, and I find it's actually very quick and effective and has certainly reduced any issues that I've ever had with cannulation. It also helps us to do things like insert into the correct vessels. So I think sometimes we get reports of puncturing what we thought was a fistula and then getting a big hematoma. And when you look on ultrasound, you realise that the artery and the vein were sitting very close together, and it's possible that the puncture was actually through the vein and into the artery. Some of the lessons that I've learned with my years of using ultrasound is it requires some training and practice to acquire the skills, but it's really worth, investing in that time. Unfortunately, in units that I've worked in, when we've got the ultrasound, we went on the assumption that we could just continue to be experts and bring in this new skill of ultrasounds and be able to just continue cannulating and assessing and have no issues. But what we found was that the staff would realise very quickly that there needed to be some new training and some acquiring of extra skills in order to be able to hold the ultrasound probe and cannulate, or just getting familiar with the ultrasound. And that led to a bit of frustration and probably a bit of lack of use of the ultrasound. It would sit in the corner. So it's really important to have a good training program and a competency assessment. Have your staff trained up and those staff to continue to train new staff. I like to have a competency and assessment package which includes a bit of theory, then some training on a phantom arm or a phantom gel mould, and lots of training with that, supervised so that they learn quickly. And then I get them to scan fistulas that aren't being used yet, so the patients aren't getting distressed because they're being delayed to be put on. So really good ones is if you've got patients on dialysis who are on dialysis with a central line and they've got a fistula that's maturing, you put them on their dialysis, and then in that downtime you can go over while they're on their dialysis and scan their arm and not have them waiting. I then do ultrasound guided cannulation training on the phantom, multiple practices, and the beauty of the phantom is it doesn't feel anything. You can just practice many times. And then I require 10 supervised cannulations on AV fistulas and grafts on the really simple ones first, and then we move to more complicated ones. And I think that this is essential, and it's really improved the uptake of the ultrasound then and people's confidence and competence. Once you do get that confidence and competence, what I find is that there's never enough ultrasounds to go around, because people do quickly discover that the ultrasound improves their abilities, their skills, reduces infiltrations, reduces patient distress and staff distress. And very quickly staff and patients like to have the ultrasound available and usable, particularly in difficult cannulations. I find that there's a perception that it will take more time to cannulate utilising ultrasound guidance. This quickly goes once you get the staff trained and competent. They quickly realise that they don't have those multiple cannulation attempts that you used to see. You think it might take a little bit longer to set up the ultrasound, but if it means that you get the needle in one time with little fuss, you actually get the patients on quicker, and the patients very quickly realise that they're not having multiple attempts, they're not being delayed, they're not having to come back the next day if there was a missed cannulation or go back to their central line. There is also a bit of a perception that staff will lose their skills. I find that actually the opposite. I find that when you are using the ultrasound in the dialysis setting, you learn what you are feeling. You learn more because you can actually see, and you learn a lot more about what does, an unusual thrill feel. What does that mean? You learn to assess better, you learn to cannulate better, and it makes me, and certainly other staff that I know that use ultrasound, it makes us better cannulators with and without ultrasound. It's important that you recognise that this piece of equipment will be used between multiple patients, and you develop a strict infection control guide or practices within your unit with regards to use between patients, and recognising that you're using this to puncture a vessel and that there's a risk of transmitting infections and bloodborne viruses, so you need to be covering the probe, disinfecting appropriately, and making sure that you're not increasing the risk of infection between patients. Okay, ultrasound basics. So I'm not going to go too in depth. I really feel that for dialysis nurses, we don't need to know a lot about the physics and stuff behind the ultrasound machine. I think that I would always recommend in a dialysis setting for straightforward assessment and cannulation that we stick to very straightforward portable ultrasounds with minimal knobs and buttons and stuff, because I do find that it really puts the nurses off. I just like a straightforward portable ultrasound with an auto gain, with a single vascular probe, and not too much to really deter or scare the nurses. Okay, but in general, ultrasound utilises sound waves that are beamed to a medium. The sound waves are reflected from that medium and back to the probe, and this creates the images. Now, how much or how little of the sound waves are reflected back to the probe really depends on the structures that you're imaging. So that the denser the objects that you're imaging or the structures that you're imaging, the more sound waves get reflected back and the brighter the image is. And the less dense, the less goes back to the probe. So we'll have a look at an example of that in a minute. So images on the ultrasound do appear in shades of grey. Basically, the more echogenic, the lighter the image will be, and the less echogenic, the darker it will be. So if you look at the images that are here, you can see that some of the images are a lighter image. That would be your denser things like bone, fascia, and then the stuff that's less echogenic would be things like muscle. And then anechoic would be things like fluid, particularly blood, edema. That would give a almost black appearance. And you can see here there's an image of a vessel, and you can see the actual blood in the vessel is almost black. The probe that you would use in the dialysis setting for vascular access would be a vascular probe. There are a few different ones, but if you're looking at getting an ultrasound, or if you're going to use an ultrasound, it'd be best to make sure that you do have a vascular probe. The L25 is nice for cannulation because the images it's just small, and it means that the images that you get are big. That's really important when you're trying to guide a little tiny needle into a small vessel. The bigger it looks, the easier it is to follow. So most dialysis units would already have a suitable ultrasound with a vascular probe, but it really does need to be a high frequency linear array, 7.5 megahertz or higher. I usually just make sure I speak to the reps if I'm ordering one and let them know what I'm using it for, so that I get the correct probe and the correct software. The ultrasound beam, it's very narrow. It's like a piece of paper coming out of the end of the probe. That's what I ask people to imagine, that there's a slice of paper. The beam thickness is about 1 millimetre, and it projects directly out, so you do have to be very careful about tilting the probe. So aiming, the way you aim the probe, you really need to look at where you're actually angling or projecting the image to, the sound waves to. And the beam produces a two-dimensional image. With the scanning, make sure your probe positioning is correct. If you just always set yourself up the right way, it means that what you're looking at doesn't get confusing for you. So there are some little markers, and you can see here there's a marker on the left of the image there, and there's a marker on the probe, and they match up. So if I was to have the marker on the left-hand side, that would be what I would see. So the trick is that if you pop the probe onto the arm or wherever you're scanning, if you move the probe left, the image should move to the right. If you move the probe to the right, the images should move to the left. So in this particular case, we can see a vessel in the middle there. If you move the probe to the right, the vessel would move to the left in your image. This is particularly important when you're using it to do cannulation, because if you're inserting the needle and it's slightly crooked and you want to straighten it, if you've got the markers, or if you've got it the wrong way round, you'll be trying to move your needle to the right and it'll actually be going to the left on you because it's the wrong way round. So just get familiar, and that way you'll just get your brain sort of set up to understand which way's which. Know your basic vascular anatomy when you're scanning. Don't forget that that's a really important tool, that you know where your radial artery is, you know where your brachial artery is. This will help you have a bit more information when you're trying to work out what vessels are what you're looking at. So when you're setting up to do your scanning, I think in the dialysis unit it's probably best to just always cover your probe. If we're scanning fistulas, even though they may have not been punctured today, they've got scabs on them and they've got healing puncture sites. So it's just best to cover your probe, and that way you're not risking contaminating your probe and then someone may be picking it up and using it on someone else with a bit of debris or something on it. We definitely should be cleaning between anyway. But so I like to cover the probe whenever I'm using it on a patient. But if you're really not going to puncture the skin and then you're really sure the skin's intact, then you could use the probe there and use a non-sterile multi-use gel. But if at all you're planning to puncture, or there's a skin break, or you're really not confident, or the patient has some sort of multi-resistant organism, I would prep it. And be prepared. Prep the skin first if you're going to cannulate, and then you want to have a look, even if you're maybe not going to use it to guide your cannulation, prep your skin, because if you then decide to go ahead and use it to guide your cannulation, if you've used your sterile probe cover on non-prepped skin, you'll have to change your probe cover. So the steps I use, I prep the skin with my unit's approved skin prep. I use my non-sterile multi-use gel on the actual probe, and then I cover the probe using a sterile sleeve. In my unit, we just get sterile freezer bags. They're very cheap, and they come with a little sterile elastic band or a couple of sterile elastic bands, and this certainly takes away the concern about cost because they really are quite inexpensive. I make sure there are no air bubbles. So this is another common error, is that you don't put that elastic band nice and tight, and make sure that there's no air bubbles in the gel, because air bubbles in the gel, the sound waves can't travel through, and that will just make your image not correct. Then I put sterile gel on the outside of the sterile cover. So there is lots of different sterile gels out there. You can use any gel really. I use a sterile KY jelly that comes in sachets, but it has to be single use and sterile. When you're scanning, hold the transducer comfortably. So get yourself in a position where you're comfortable, you're holding it comfortably, because you may think that it's just going to be quick, but if you're scanning for 10 or 15 minutes to create a map, you can actually get quite uncomfortable and cause some muscle strain. So hold it comfortably. Keep a really light touch, because compressing the vessels or pressing down with the probe may distort the vessels and give you the wrong image. Make sure you stabilise your hand, particularly if you're scanning with a lot of gel. It's very easy to slip off and move around, so stabilise yourself and relax. The probe, ensure that you're aware of the angle of the probe when you're creating a map or needle. Make sure the slightest little tilt of the probe or change of the angle has quite a big effect on where you're actually scanning, particularly with the deeper vessels. A slight tilt in the angle on the surface results in quite a big arc and a big difference on where you think you're looking. So be really aware that you're at 90 degrees to the surface, pointing down at what you want to see, or if you're tilting it, that's what you've planned to do. Be aware of what your probe's actually getting an image of. Here's a good example. You can see here that the probe is tilted, and you can see the shaft of the needle, and on the image on the right you can see the wide of the shaft of the needle is almost at the surface, and you could be fooled into thinking that that's the tip and continue to advance, when really if you'd have been looking in the right position you would have realised that the tip was already in the vessel. That's a very common error. I've seen that a lot, where the staff is saying to me, but it's not in the vessel yet, and the patient's going, ow, ow. And when you move and tilt it correctly, you realise that they've gone and they're actually poking it back out the other side, down on the bottom. So you can see here now the change in the tilt has got it in the correct place. The environment, it's really important to set yourself up. People avoid it because they think it takes more time, but trust me, it actually takes more time if you don't set yourself up correctly from the start. It takes time in making it more complicated, making it difficult, and putting people off using ultrasound. I like to get my ultrasounds in my line of sight, so I move the dialysis machine, or I move the chair and I line my ultrasound up. I plug it in and make sure it's not going to lose battery on me halfway through a difficult cannulation. I have my probe cover on and ready, and I have myself set up so that I'm ergonomically set up so that I don't end up with strain for myself, and I also don't have to tilt my head and risk the probe moving from where I want it to be. It's very important. I can't emphasise this one enough. When you're scanning, again, don't press down with the probe. You've got to support the weight of the probe and just have it gliding in the gel on the surface. You can't have air between the probe and what you're scanning, but you can just have it skimming in the gel. Don't press down. It will actually occlude low pressure vessels like some veins. It will distort the shape of the vessel. So if you were trying to get a diameter measure of your cephalic vein, for example, and you were compressing it slightly, you'll actually get an incorrect diameter. So here's an example of a cephalic vein. It's a lovely round circle, and then with compression you can see that it compresses down, and it really, with a low pressure vessel, doesn't take a lot of pressure. Even just resting the weight of some of the probes on can mean that you can lose the vessel altogether and think there's nothing there. It really helps to determine your anatomy. There's a couple of tricks. So if you're using the ultrasound to make a map or to guide cannulation, it's really important that we distinguish between the arteries and the veins. We use our anatomy. It's really important. We know where our arteries are. We know where the veins usually are. We can, have an idea. With the shallower fissulas, we're sort of pretty aware. We can palpate them. But with the deeper vessels, sometimes it is a little bit tricky. And certainly in some areas, we do find that the arteries and veins run very close together. So one of the tricks is to compress. So when you've got two vessels close together and you're not sure which is artery and which is vein, or if you're looking at one vessel and you're just not sure, the trick is to push down with the probe. What you'll find in general is with a low flow vein or low pressure vein, it will compress, and with an artery it will stay round and it will start to pulse more. So that's a trick. Unfortunately, with some of the high pressure fistulas with outflow stenosis, they tend to be pulsatile and don't compress easily. The difference is that they'll usually be quite large and dilated, and there you'll have to rely a little bit on your anatomy. So some of the anomalies that we see with ultrasound. So this is an aneurysm. People always wonder what's the difference between an aneurysm and a false aneurysm. So an aneurysm is that the entire vein wall has dilated up and become larger, but the blood is still within the vein structure, so that's an aneurysm, and this is a true aneurysm. The reason why we captured this image was that the staff were being very good and trying to move their cannulation spots, and because the vessel was quite deep in some areas, they'd been puncturing the aneurysmal bit and wanted to move a little bit higher up, and punctured assuming that that would also be shallow, but were just not able to hit the vessel and they weren't really sure what was going on. So we put the ultrasound on and we could see that the segment further up where they were trying to puncture and hit the vessel was actually 1.5 centimetres deep, and so it was just too deep for them to needle. So it helped them to get a map and make a plan on the best areas where they could move around to try and minimise the area puncturing that this patient was receiving. This is a false aneurysm, so this is the difference. So this aneurysm has been caused, unfortunately, by a needle that's been inserted and then pierced through the back wall, and the tourniquet was probably still on, so there was a fair bit of pressure which allowed it to bleed out into the tissues behind it. So this one means that the blood is no longer in the vessel wall in that aneurysm. So they're a little bit more dangerous because the vessel wall isn't containing it. They can become quite large, particularly if the fistula has an outflow stenosis and it's under a lot of pressure. Those can become quite large, or they can get infection in them. So they're ones that you really need to keep a close eye on. The benefit of using ultrasound to guide cannulation is that you probably wouldn't have had this happen if you'd have used ultrasound to guide the needling, because you would have been able to watch the needle tip and make sure that it didn't pierce back out the side or back out the bottom. Here are a few other infiltrations. So the more we start to look with ultrasound, the more we realise that every time we insert a needle and we lose flashback, we're putting a hole somewhere. The flashback's stopping because we've pierced the needle tip into the vessel wall again. So these are some of the infiltrations that you start to see when you're looking with ultrasound. So the first one on the left, there was a whole lot of hematoma sitting over the vessel. The staff were palpating to cannulate and feeling the hematoma and thinking that the vessel was actually quite shallow, but it wasn't vessel, it was hematoma. And they were trying to repuncture in that area and not getting any flashback, so started to sort of change the position and cause more trauma and hematoma because they didn't realise that the vessel was actually too deep through the hematoma to puncture. And the one on the right, you can see that they've probably punctured, and as they've threaded, they've accidentally just pierced the side wall on the right just a little bit, and it's bled out and around. So this certainly would have been painful for the patient and resulted in some bruising, and if it was much bigger, it could have even compressed the fistula. This is edema. It's quite a nifty little trick that you can tell the difference between edema and fat, because edema does have the darker areas, which are the fluid, so there's really fluid in and around and amongst the tissues there. So that's edema, and this is edema on a patient who has a central stenosis and their arm is very swollen, and this is the edema. This is thrombus in an AV fistula vein. This is a non-occlusive thrombus, so the fistula still had some thrill, and there was just a small plug of clot in the cannulation zone, and the staff were attempting to puncture and saying, that they weren't getting flashback and they weren't sure what was going on and thought they were missing the vessel. But when we put the ultrasound on, we realised that there was some thrombus in the vein in the area where they were cannulating. In this particular case, because there was flow around it, we were able to puncture above and below the thrombus and provide a dialysis session to make the patient stable before they went to theatre to have a thrombectomy. If you're not sure, sometimes if you've got your gain turned very high, everything's wider, or there's just more reflection back, everything has more echo. So if you're not sure if that sort of white cotton woolly stuff in the middle of a vessel is true thrombus or not, the trick again is to compress it with the probe. If there wasn't any thrombus, the vessel would be able to be compressed. If there was thrombus, what you would see is all those black areas where there's blood, that would all squish down, but the thrombus would remain as a plug that hasn't compressed in the middle of that vessel, which is what we saw in this case. The other thing you can do is turn the colour on, and you'll see that there will be flow or colour related to the flow in the areas where the blood's still flowing. This is a stent, so this is a nice example of the metal is very echogenic, and because it's very dense, so the struts of the stent are really sort of giving us a lot of echogenicity, so that's quite nice. The stents we are seeing more and more often in the middle of cannulation zones. It's becoming a common practice, and they can be a little bit tricky to puncture and thread a needle through. The needle tips tend to hook, or the back eyes hook. So having the ultrasound helps us sort of to guide through and see where it's catching and maybe change the angle to get through the holes in the struts of the stent. This is a back wall with infiltration. So on this particular occasion, they'd attempted a puncture and had lost flashback, and when we look with the ultrasound, we can see that they've punctured and the vessel's probably not had quite enough tourniquet, or it's very low flow, and so when they've pushed through the top wall, the vessel's probably collapsed, and by the time they've pushed through the top, they've also pierced the back wall. We were able to rescue this one because we were able to pull the needle tip out of the back wall and then rethread using ultrasound. If we didn't have ultrasound, we wouldn't have known what was going on, and we may have tried to even puncture in the same or similar area, and that infiltration on the back, narrowing the lumen, would have made it very hard for us to repuncture and thread. This is a track that we recognised. We were feeling a new thrill in the middle of the fistula, and when we put the ultrasound on, we could see on the left there in the black and white image the track running along the top, and this is actually quite common. It's when the patients or the staff have held off the external puncture in the skin but not had their pressure over the actual puncture into the vessel, and the blood has been able to leak out of the vessel and into the surrounding tissue. And this one we wanted to confirm, we could feel the thrill, we wanted to confirm that there was flow. So we've turned the colour on and you can see there's actually flow in that track. So that's something we would want to keep an eye on and make sure it's not becoming larger. It's also something that with ultrasound we could actually provide a bit of compression to that track for a few minutes and stop the flow out of the fistula and seal it off. So creating a map of an arteriovenous fistula or graft, you can ultrasound the graft to make a map, and this helps to guide future cannulators. It helps as a bit of a history, so we can refer back to it in the coming months or years to see if there's been a change or if there are any concerns that we had, whether they've worsened. The map should note the anastomosis or the anastomoses if it's a graft, the depth of the cannulation zone vein, the diameter of the vein that we want to puncture, any branches or collaterals or any other areas of concern, like if there are any valves or infiltrations or anything, stenoses that we're worried about. It may help identify issues like small inflow arteries. We get a lot of fistulas that have failed to mature, but we're not really sure why. There's nothing obvious in the way of a stenosis clinically, but when you look at the inflow artery, the radial artery, or it is very small, it hasn't dilated up, and it may be heavily calcified, so that that might be something that you can then send to the surgeon and say, there's no real stenosis in the vein, but the whole artery is very small and the flow is not very good. We can also identify significant narrowing of the fistula vein. We can measure that and keep that in the history for future reference to make sure it hasn't gotten worse. We can identify collaterals and branches so that we can, particularly in deep vessels, so we can alert staff to the risk of, having trouble puncturing in those areas and advising them to avoid certain areas. I keep blank templates in my unit. The staff could just print them off, and they don't have to be artists then. They just have to draw the vessels onto the arm. So here's a couple of examples of mine. So on the left is a PTFE graph that tells the staff the direction of the flow, so that helps them knowing which is the arterial and which is the venous. It has it just helps them to understand if there are any issues, or if they see something new like a collateral off the outflow, they might be able to identify that there's something's changed if they rescan it later on. And then on the right is a native radiocephalic arteriovenous fistula. I've been able to identify the diameter of the radial artery, and we can keep an eye on that. It's a little bit small, but hopefully that'll dilate up. I would identify if there was any narrowings and what their diameter were. I've noted the diameter of the vessel. It's not quite the diameter we would like, so we'd keep monitoring that. And I've noted the depths as well, and that there is actually a branch in the mid-forearm, and how far above the elbow crease that is, particularly in the deeper vessels. If you can't palpate it, sometimes people will palpate just before it branches. It will feel nice and wide, but they won't realise that it's actually branching left or right, and then when they thread it, they actually have an infiltration. So ultrasound-guided cannulation. Before you do your cannulation, take the time to scan. So don't just plonk the probe on and decide that's where you're going to do your cannulation because that spot looks good. Take the time to scan and choose some optimal sites. And if you're doing ultrasound-guided cannulation because there'd already been some difficulties, you definitely should be having a good look at the fissure to make sure there wasn't a reason for there being a difficult cannulation. There's been a few times where I've been called because of difficult cannulation and realised there was actually some thrombus in the vessel. Select your optimal depth and gain on the ultrasound. I prefer to set my depths quite shallow. That just makes everything bigger. So if you make your depth, on mine I can go down to 1.9 centimetres deep is my scanning depth. So that means that my vessel is quite large and the needle tip is nice and large, and any corrections I can make, it's very easy to adjust. Scan the vessel in both planes. So even if you're going to do in plane or out of plane, whichever you're going to do, scan it in both planes so you get a good idea and a 3D map in your mind of where it is and the direction that you're actually going to thread the needle and puncture in. Plan your needle length. This is particularly important for deeper vessels, but also the vessels that you think are shallow. Again, they may have an infiltration and they may not be as shallow as you think, or some of the big aneurysmal fistulas can have a little bit of luminal thrombus, which, you think this big aneurysmal fistula, you should be punctured very quickly, but when you put the ultrasound on, you realise that there's a little bit of thrombus just lining the lumen, and actually to puncture into the blood, it's 5 or 6 millimetres deep. So, sometimes I find that people are a bit confounded with the big aneurysmal fistulas and they don't realise they're actually deeper than they look. So measure your vessel depth. You don't have to use the calipers. You can use the guides on the side if you're just needing a gauge, if you're not having to save it for future. Make sure your length is definitely suitable for the depth and the angle that you're inserting at before you start inserting. And remember that there needs to be enough not only to puncture the vessel but to thread the entire bevel into the vessel. So A common error is that we look at something that's a centimetre deep and think, well, you know, this normal length needle should make it, but you forget that by the time the vessel puckers a little bit and then you push through and then thread it enough to be safe, you actually needed, you know, more than your 2.4 centimetre needle that you've got, or you've needed to go at a steeper angle than you had actually gone at. So you can work it out. So a bit of trigonometry, we thought we'd never use it, but it does come in handy after all. We can work out that if I want to puncture down to 1.2 centimetres at a 30-degree angle, I need at least a 2.4 centimetre needle, and that's my common needle. So if I wanted to be safe and have a little bit more room to move, I would probably suggest going to a longer needle if I had to needle something that was 1.2 centimetres to the middle of the vessel lumen. So here, this helps even, I certainly noticing more and more obese patients coming on dialysis. They have fistulas created and they come to us and we're told that we should be able to cannulate them. It's very difficult to palpate, but we don't know how deep. We just know it probably is deep, but we don't know how deep. So we cannulate. If we don't have ultrasound, we would cannulate in the hope that we'll be able to reach it. And if we had the ultrasound, we could actually put that on and measure the depth and say from the beginning, it's actually too deep, you need to superficialise it. Or even if it's not too deep, it's very good to have the ultrasound to guide the cannulation, because if you're off track just the littlest bits, I'll show you with my arrow, if I start at a slightly crooked angle and I insert into this vessel just on a slight angle, I'll still puncture fine. But if I start inserting here and I insert on a slightly bad angle, that angle with the fulcrum becomes wider and wider the deeper I go, and all of a sudden I've actually just cut a hole in the side of the vessel. I get a little bit of blood bleeding up into my needle and I get those clots that we talk about where we think that the vessel's clotted, but actually it's just because we've just cut a hole in the side, put a little bit of blood in and it's clotted the needle. So having an ultrasound to keep my needle tip on track the whole way down, keep my angle right, I'll be able to get into those deeper ones. Another thing I see a bit of that we don't realise we're doing until we look with ultrasound is that this fistula was a little bit soft and needed really good tourniquet, but it was new, so we were a bit nervous about using too much tourniquet. They've punctured and this is tented down. By the time they've pushed through, they've nicked the back wall. Just made a slight little hole in the intima. The blood has filled that intima and reduced the actual lumen size quite dramatically. And you can imagine that on this cannulation they wouldn't have been successful. They would have possibly tried to change the angle, but because they would have been hooked in this, if they didn't have ultrasound, they wouldn't have realised and they would have probably abandoned. And then the next person who comes along would see that people have been cannulating there from the punctures and probably choose to cannulate in a similar area, maybe puncture here, and then not realise why they can't thread through and probably cut through this again and make this infiltration even worse. So having the ultrasound from the start would help us to decide to probably go over here instead and avoid that, or use good tourniquet and puncture here and then be able to watch ourselves thread through this lumen and out to the other side. So that really does minimise the impact, because if we continue to puncture there and re-puncture that back wall, that would set us up for failure for many, many, many weeks. So the orientation of the transducer to the vessel, there's the short axis and the long axis. So the short axis short axis is also known as transverse. So any patent arteries and veins appear as round or oval anechoic structures. So you can see here there's a couple of black vessels. I just from experience know that's a vein. You know, your arteries are usually round and firm, and your veins, particularly the bigger veins, can be a bit bit wider, but in your arm vessels, these are neck veins, but in your arm vessels, this would probably appear rounder and slightly bigger. But the trick is to compress the vessels, and you'll again see straight away that the artery becomes pulsatile and stays round, and the vein compresses quite flat. Okay. With the transverse insertion, I quite like that because I can visualise all 4 walls. So I like that as I go in with my needle, I can avoid this wall, this wall, this wall, all the sides. So I really like using this. I find that it really helps me, but it does take a little bit more skill because you only see the slice of the needle that you're actually imaging. So it is possible to accidentally be imaging the shaft of the needle and the tip is already in the bottom. So you need to be very careful and get lots of practice and get some skill in making sure that you at all times keep your eye on the tip of the needle, not the shaft. Also be very cautious to insert at the correct angle. So have your marker the right side to your probe. Again, remember that when you move left, the vessel will move to the right. When you move to the right, the vessel will move to the left, and it's the right way. Otherwise, if you're inserting and you're slightly crooked to the left, you'll try to adjust to the right, but what will happen is that the needle will keep moving to the left and you'll be very confused. So that won't happen with that. So it's important that you have your marker the right way round. If you're inserting a little bit off centre and you've got the marker the wrong way round, when you try to correct, because you see you're coming in a little bit over to the left here, you'll try to adjust to the right, but your needle will keep moving more left, and that's because you've got your marker on the wrong orientation here. So remember that when you've got your probe on, move it to the left, and your vessel should move to the right, move it to the right and your vessel should move to the left. And that way, if you come in a little bit crooked and you decide you want to straighten up to the right, it'll go right when you think it's turning right and you won't have confusion. Okay, so the trick is centre the vessel, make sure it's absolutely in the centre. I like to use these dots, these guides here, and have my vessel right in the centre. I make sure that my slice I've lined up so that my slice is directly cutting through the vessel the way I want it to. I have it with the correct orientation to the marker and the correct angle. I start with my puncture, and a lot of the probes have a little arrow here, so I start with my puncture. If I know I'm centred and I start my puncture where that arrow is and I've got it at 90 degrees, not slightly crooked, if I've got it at 90 degrees, if I keep going down in that path, I will puncture right in the centre of the vessel. So your arrow lines up with these lines. So if you go in at 90 degrees at that line, you're guaranteed to hit centre. If you go off a little bit, that's different, but you just go slow. You watch your needle tip, and once you've punctured, you don't look at your skin anymore, you look at the image and you watch. As your needle goes down, move your probe forward, move your needle forward, move your probe forward, move your needle forward, move your probe, and that way you can watch your needle tip all the way till it starts to puncture the vessel. You'll usually know you're about to puncture because the vessel starts to tent in, starts to bow in, and then it pops through, and then as you're threading along, again, you can make sure now that you level out and you don't continue through the back or the side walls, and you can watch yourself moving down the absolute centre of the vessel until your needle's in as far as you want it to go in. So I really like that. It does take some skill and practice, and that's why the phantoms are fantastic. You can do 20 insertions in a minute if you want to, you know, whereas on a patient, they're certainly not going to let you do 20 insertions. So use those phantoms, have lots and lots of practice before you go to a patient, and then start on the really straightforward ones that look like this one in the image here. Start on those. So this is an image of the needle going in. So you can see as the needle gets inserted in, and we're following the tip as it goes down and into the vessel. In the longitudinal plane, you can see we can see the entire vessel here along under the probe. It helps us to identify structures like valves or little collaterals or branches. You know, I certainly wouldn't like to insert my needle into there, because what would happen would be I'd get a flashback here. If I wasn't doing it with ultrasound, I would think I was in and start to level out, and then I'd be in trouble. So I would probably avoid cannulating there, because I'd have to cannulate through a collateral, so I'd be avoiding that. So the longitudinal, even if you're going to do a transverse insertion, look longitudinally and make sure that if you puncture here, can you thread? And you probably can't, so pick your sites better. With the longitudinal insertion, you can visualise your whole needle. So the nice thing about this is you're not going to accidentally have your shaft, be visualising your shaft and think, you know, you haven't got in yet and continue. So here you can see the whole length of the needle, and you're not going to accidentally put your tip through the bottom wall. But the risk here is that the slice through the vessel, if you go a little bit off angle, you may start to thread towards the side wall. So it's a lot trickier, because this is a very thin slice. It's very tricky to keep this all in the image. If you move your probe just slightly left or right, you'll lose your needle and you'll lose the vessel. So it is tricky to hold it and image it. So with the longitudinal, like I said, make sure that you've got the slice right down the absolute fattest part of the vessel. That way you know that when you puncture, you are going to go into the centre of the vessel, not to the side. So if you put a slice through here, it will look like this, but you'll actually be in the side wall, and you risk being very close to cutting out the side. So the other trick is that if you just move your probe left and right across this, it will get narrower in the thinner slices, and you pick your widest point. That will be where it's widest in the vessel. So make sure that you move back and forth to determine where you are on the widest. And your walls will be a brighter white or a brighter grey in the absolute centre of the vessel. That's just something you'll become familiar with as you start to scan more and more. So this is an image of the needle just coming in through from the top of the screen and into the vessel, and you can see that it threads in nicely. Make sure that when you do your insertion, you use your step-by-step. If you're doing the transverse, you start with your needle tip exactly in line with the arrow, centre your vessel so that it's in line with the arrow, then start by looking at the skin and planning your puncture that it's going to be at 90 degrees. Then once you've punctured the skin, start to look at the ultrasound screen and watch the needle tip. So advance your needle, advance the probe, advance your needle, advance the probe, advance your needle, so that at all times you're visualising the tip of the needle. If you lose your needle tip or you're not sure, stop and move your probe past so you don't see any metal anymore, so you don't see any of the little circle. Move it past and then bring it back slowly, and as soon as you start to see the metal dot, you know that that is your needle tip. Okay, some clinical pearls. So the setup, I can't, emphasise enough. Just take the time to set up. It actually does reduce the time to successful cannulation, particularly. So line your machine up correctly. Make sure that you're not going to hurt yourself by not having your ergonomics right. Make sure that your vessel or your arm or your leg is in line with the ultrasound machine, so that you can actually visualise by just looking down at the arm and then looking up at the screen, that you're not having to turn your head to the side. So just get it all right. Move things if you need to. It's worth the effort. The other thing is, just don't set your staff and your patients up to fail. Give them the training. Take that little bit of effort. Remember that it is a new skill, that even though you may have some of the best expert cannulators and expert clinical assessment staff in your unit, that doesn't mean that they don't still need to be supported and trained in this new skill. And they shouldn't be hard on themselves and expect that they can do it. It should just be an expectation that this will require extra training. So have a really good competency assessment package in place. Make sure you scan the vessel in both planes. Make sure that you scan from top to bottom if there's any concerns, and if you need to, draw on the skin. Make sure you centre the vessel if you're going to do a transverse, particularly. Centre it, use your arrow. You really can't go wrong. It really is put needle here and just go in at your 90 degrees, and it really does help. Be aware of how you're tilting your probe, where you're actually aiming that beam of, the ultrasound beam. Make sure that you are actually aiming it where you're intending to aim it. It's very easy, particularly if you're turning or if you talk to the patient, to not realise that you've allowed your probe to tilt slightly, and when you go back to it, you're not looking at where you think you are, or if you're looking at the screen, you haven't checked. So if you're watching the insertion on the ultrasound and you're just not sure that everything's right, look back at the probe, look back at the arm or the leg, and make sure that you haven't accidentally tilted your probe, and reset yourself. Ensure your marker and your probe marker are lined up. Believe me, that's a nightmare when you've got it the wrong way around and you're trying to adjust your needle tip slightly, and everything you think you're angling to the right, it's going to the left. It's very confusing for your head. Go slow and visualise as you go. It really actually does make a difference to the ultimate end result. So even though you may be rushing, it actually makes things longer. So take a little bit more time to just slowly do everything, and you'll find that you're more successful and it's all quicker. If you lose your tip, or if you're just not sure, stop and recheck everything. Okay, and like I said, practice. There are lots of sites online that give you recipes to make your own gel phantoms, or you can buy your own phantom, but it's definitely worth the investment. Thanks so much for your time.